This is Health. Welcome to this week's podcast. In this week's podcast, we're looking at gastroesophageal reflux disease. We start off with a definition of the condition. Gastroesophageal reflux disease, or GORD, is inflammation of the esophagus leading to an unpleasant burning feeling, which is felt behind the breastbone and often accompanied by a sour or bitter taste in the mouth. The most common form is reflux esophagitis, which is caused by frequent regurgitation of gastric juices as a result of abdominal relaxation of the lower esophageal sphincter. It may be associated with a hiatus hernia. Other contributory causes include pregnancy, constipation, and obesity. Symptoms are mainly regurgitation of a bitter-tasting fluid, heartburn, and perhaps difficulty swallowing. Some patients may be hoarse, have a hoarse voice, and have breathing difficulties. If heartburn is experienced regularly, investigation by endoscopy may reveal esophagitis, which is inflammation of the inner lining of the esophagus. This may lead to complications such as esophageal stricture or Barrett's esophagus, where the normal cube-shaped cells that line the gullet become replaced by elongated cells as a result of damage from the stomach acid. Long-standing and untreated Barrett's esophagus may lead to ulcer and a high tendency to undergo malignant change. The majority of sufferers have endoscopy-negative reflux disease, where reflux is the predominant symptom, but a normal endoscopy result is seen. And now we consider the triggers for gastroesophageal reflux disease. Foods such as fatty foods, citrus fruits, onions, and coffee are among the triggers, as binge eating, certain drugs which relax the lower esophageal sphincter, such as calcium channel blockers, theophylline and nitrates, smoking, alcohol, obesity, sometimes bending over or lifting something, and finally genetic factors have all been identified. You need to be conscious about warning signs when you need to refer gastroesophageal reflux disease within a pharmacy setting. Such warning signs include gastrointestinal bleeding, swallowing difficulties, progressive unintentional weight loss, persistent vomiting, iron deficiency, anemia, an epigastric mass or a suspicious barium meal. Anyone presenting with dysphagia, unexplained weight loss, or any other of the alarm symptoms that we've discussed should be routinely referred to their GP, as this may suggest esophageal or gastric carcinoma. However, some symptoms will need urgent referral, such as dysphagia with a complete inability to swallow. As usual, you want to undertake a thorough differential diagnosis to rule out conditions such as cardiac pain, side effects of medicines, irritable bowel syndrome, motility disorders, and biliary colic. Cardiac pain is frequently mistaken for dyspeptic pain and is often difficult to distinguish. But pain traveling down the arm which is not relieved by antacids is one possible distinguishing symptom, and you should consider accompanying symptoms such as being pale, cold, clammy, or having breathing difficulties. In terms of side effects of other medication, you need to identify any other medicines that may be taken, that are being taken to rule out an adverse effect. NSAIDs, iron, biphosphonates, or corticosteroids come into mind. Irritable bowel syndrome may also present with similar symptoms to gastroesophageal reflux disease, especially accompanied by bloating, although there would usually be abnormal bowel habits reported as well. Motility disorders may be a possibility, which would require referral to the GP. And biliary colic may present as epigastric pain precipitated by eating. Cardiac pain will not be relieved by an antacid. It's sometimes brought on by exercise and relieved by rest and glyceryl trinitrate. If there's any doubt about whether it is cardiac pain, refer the patient urgently to emergency 999 if required. The principal distinguishing feature is the periodicity, and that is relating to eating, exercise, and such factors. Patients reporting a first episode of gastroesophageal reflux disease or dyspepsia at the age of 40 or above should be referred because of the possibility of gastric cancer. And so we move on to a discussion of the treatment options for gastroesophageal reflux disease, which are similar to those for dyspepsia. Look at antacids, antifoaming agents, alginates, H2 antagonists, proton pump inhibitors, and motility stimulants. The approach to treatment depends on the diagnosis and severity of symptoms. These symptoms may be severe with the risk of erosion and malignancy and require immediate investigation, or mild or non-erosive when lifestyle changes and antacids may be the first choice. And so looking at simple antacids, there is limited evidence on the efficacy of antacids in the management of dyspepsia. However, symptomatic relief is often reported with the use of an antacid or alginate. They're best given when symptoms occur or are expected, that is after meals and at bedtime. They also remain in the stomach for longer at these times and therefore have longer to act. Antacids should preferably not be taken at the same time as other drugs, as they may impair absorption. Combination antacid products containing both magnesium and aluminum salts are less likely to cause gastrointestinal upset. Magnesium salts on their own may cause diarrhea, while aluminum salts alone may cause constipation. The antifoaming agent that we think about is simeticone, which we shall discuss in our next module on colic. Alginates taken in combination with an antacid increase the viscosity of stomach contents and can protect the esophageal mucosa from acid reflux. Some alginate-containing preparations form a viscous gel or a raft that floats on the surface of the stomach contents, thereby reducing symptoms of reflux. The amount of additional ingredient or antacid in individual preparations varies widely, as does their sodium content, so preparations may not be freely interchangeable. H2 antagonists such as ranitidine suppress acid secretion as a result of histamine H2 receptor blockade. The maximum single over-the-counter dose of ranitidine is 75 milligrams, and we need to remember that it is not licensed for sale over the counter to children under 16 years or to patients who are pregnant or breastfeeding. Adverse effects of H2 receptor antagonists include gastrointestinal disturbances and relatively rare hepatic impairment, which is a precaution or contraindication to their use. Impotence has been reported, especially with cimetidine. PPIs produce a similar pattern of adverse effects and may mask the presence of gastric ulcers. And PPIs such as omeprazole, pantoprazole, and esomeprazole inhibit gastric acid secretion by blocking the hydrogen potassium adenosine triphosphatase enzyme system, which is also known as the proton pump of the gastric parietal cell. Evidence for their effectiveness refers to healing ulcers than relief of symptoms of GORD. It shows that proton pump inhibitors are more effective at healing than H2 antagonists or antacids. A NICE 2014 guideline states that they can be used on demand to relieve symptoms as they occur. They are well-tolerated drugs with side effects reported as diarrhea, headache, and dizziness. While omeprazole 10 mg tablets may be sold for short-term relief of reflux-like symptoms in adults above the age of 18 for a maximum of 4 weeks, esomeprazole is only licensed for adults aged 18 and above for a maximum treatment period of 14 days. And so it is important to ask patients if they have a referral for endoscopy before they purchase PPIs, as they should not be taken 2 weeks before endoscopy, since they may mask the underlying pathology. Motility stimulants are dopamine antagonists such as domperidone and metoclopramide. They enhance the power of the esophageal sphincter contractions, and they stimulate gastric emptying, and thirdly, speed up the passage of small bowel contents. Adverse effects of motility stimulants include acute dystonic reactions consisting of facial and ocular spasms, especially in children and young women. This may be treated with an injection of procyclidine, which is an antimuscarinic drug. However, you should remember that domperidone is no longer available over the counter. And so we have a summary of our key drugs used for reflux esophagitis in the diagram. So antacids, you have aluminum hydroxide, magnesium carbonate, magnesium hydroxide, magnesium trisilicate, and Cormagaldox. Antifoaming agents include simeticone, which we mentioned before. Gastroprotectants are your alginates. Motility enhancers are domperidone and metoclopramide, which we've just discussed. H2 receptor antagonists are cimetidine, famotidine, nizatidine, and ranitidine. Whereas your PPIs are esomeprazole, lansoprazole, omeprazole, pantoprazole, and rabeprazole. Move on to a discussion of some practical tips that are sometimes given in relation to GERD. It's not known whether losing weight, stopping smoking, or reducing the intake of alcohol, caffeine, or fatty foods will help reduce symptoms of GERD. However, it's sensible, healthy lifestyle advice and will not cause harm. Eating smaller meals may help, and a small study looked at raising the head of the bed in gastroesophageal reflux disease and found that small improvements in self-reported symptoms occurred. One possible cause of reflux disease is transient relaxation of the lower esophageal sphincter, and when lying flat, this increases reflux episodes because gravity does not then prevent acid regurgitation when the lower sphincter is relaxed. There are some special considerations when it comes to reflux disease in children. They relate to symptoms, the resolution of those symptoms, and to thickened feeds. Children may present with symptoms such as recurrent vomiting, difficulty bleeding, a failure to thrive, abdominal pain, and irritability. Symptoms are due to the passive transfer of gastric contents into the esophagus due to transient chronic relaxation of the lower esophageal sphincter. Infants often present with frequent vomiting at less than 6 weeks old, and spontaneous resolution often occurs at 12 to 18 months. Regular treatment is, however, warranted if regurgitation is frequent. Half of babies under the age of 3 months will bring up their food at least once a day, and referral will be required if any bleeding difficulties or failure to thrive are suspected. Thickened feeds reduce the severity and frequency of regurgitation in most cases. And so you have examples such as instant carabel powder, which is carob seed flour. This should be used on the advice of the health visitor or GP. Sodium alginate may also be used to reduce the frequency of regurgitation, and Gaviscon infant sachets are an example. Care must be taken with the high sodium content of such products, and they're not recommended in preterm infants. And so we conclude with a review of our dyspepsia and reflux disease treatment algorithm. Your emergency symptoms that require direct referral to 999 include possible cardiac pain, and we've spoken about the associated symptoms where the patient is cold, clammy, or where they've got loss of consciousness. When people have breathing difficulties or where they're vomiting blood or coffee ground vomit, then refer them straight to 999. You can also refer them to the extended emergency wherein they have melena, which is black tarry stools, where they have abdominal pain radiating to the back, because that can indicate a possible aortic aneurysm. If they have dysphagia, you make an urgent GP referral, but then if they have excessive drooling and they have inability to swallow inability to swallow, you would refer them straight to extended emergency. If they have nighttime waking with acid in the throat, if they have unexplained weight loss, if you think it's a medication-related adverse drug reaction, or if there's been a failure of over-the-counter options, then you need to make a routine referral to the patient's GP. If you have rolled out all the alarm symptoms that we mentioned before, and the patient has not yet tried over-the-counter treatment, then you can look at the standard over-the-counter treatments. And so that concludes our discussion on reflux disease, also known as gastroesophageal reflux disease, GORD in the UK, in other parts of the world possibly known as GERD. And that's just simply an outcome of the way the word esophagus is spelled. We'll see you next time. Thanks for watching and for listening.